Hello and welcome. I'm Sarah Nicolay, Research Assistant at Benjamin Rose Institute on Aging. Thank you for joining us today. This webinar will be recorded. We will be sharing the link with all of you in an email in the next week. Please feel free to share that with colleagues who cannot join us today. You may submit a question at any time using the Q&A or chat feature on the bottom of your screen. We have staff monitoring to convey your questions to our presenters and to answer any technical questions you may have. I will now turn it over to Orion Bell, Benjamin Rose President and CEO, who will introduce today's program and our first speaker. Orion?
Let me unmute myself. Thank you, Sarah. And as Sarah said, my name is Orion Bell. I am the President and CEO here at the Benjamin Rose Institute on Aging. I want to thank you for joining us for today's webinar, Elder Justice Innovations, Helping Individuals Transition from APS to Other Community-Based Supports. The Benjamin Rose Institute on Aging is committed to highlighting the important elder justice work being implemented across the country. And presented in partnership today with the Elder Justice Coalition, we will hear about Administration for Community Living 2021 Elder Justice Innovation Grants, and a select group of grantees will discuss their work focused on the various community services that help individuals transition from short-term adult protective service programs to community services in their area and prevent the recurrence of abuse. We'd like to thank Bob Lancato, Meredith Ponder-Whitmer, and the Elder Justice Coalition for their continued support in making this webinar possible. Now, it is my honor to welcome our first speaker, Hillary Dallin. Hillary is the Director of the Office of Elder Justice and Adult Protective Services at the Administration for Community Living. The office coordinates and manages a federal strategy for elder justice to provide coordinated and seamless responses to transform adult victims of abuse into survivors and to prevent abuse before it happens again. The office supports elder rights and legal assistance programs for older adults and is funded in every state and supports pension counseling assistance programs. The office also closely works with ACL's Office of Long-Term Ombudsman Programs, preserving the rights of residents of congregant residential settings. Previously, Ms. Dallin was the Department of Health and Human Services Center for Medicare and Medicaid Services. Prior to joining the government, she was involved nationally and at the state level with advocacy for benefits access, elder abuse remedies, and legal assistance for older Americans. She practiced as an attorney and a manager in an Older Americans Legal Assistance Program for many years. She worked collaboratively to advance rights, access, and improvements in the autonomy rights and social determinants of health of older Americans with economic or social needs of older adults. She served as a long-term care ombudsman, legal backup and trainer in several states, and has taught elder law and health law at several law schools. She is the prior chair of the Connecticut Bar Association's Elder Law section, and she received her law degree from Boston University School of Law. Please join me in welcoming Hillary this afternoon.
I don't know if I can get the off of, There we go. Good afternoon, good morning, everybody. Thank you so much for joining this really important webinar. My task here is a delightful one of providing a high-level background to contextualize our shared commitment to the Elder Justice Innovation Grants and to demonstrate the promising approaches to transitioning from emergent interventions by APS to longer-term community-based supports that can enable the recovery of agency and all that has been lost to abuse. With 1 in 10 older Americans subject to abuse, but only 1 in 24 such incidents actually reported, we need to see elder abuse and the move towards elder justice as a matter of justice for all of us. That means if it's a justice matter that we each have a role to play, every single one of us, and also as a public health issue. I wanted to start by sharing ACL's vision for elder justice, which is up on the screen right now, which is a comprehensive multidisciplinary approach that effectively supports older adults and adults with disabilities so they can exercise their right to live where they choose, with the people they choose, and fully participate in their communities without threat of abuse, neglect, or exploitation. Next slide, please. In our Office of Elder Justice, we bring together many interrelated portfolios to support that mission. And as Orion said, we support legal services, which the Older Americans Act calls legal assistance for older Americans all over the country. We have a grant program that is working on enhancing the delivery of legal assistance, and we support a national center, resource center on law and elder rights. In income security, we support pension counseling projects across the country. 30 states across the country have these programs, and a national pension assistance resource center supporting the local counseling projects, which are staffed by the only ERISA experts in the country who are entirely consumer focused. Adult Protective Services, here we come closer and closer to the topic for today. We support state grants to enhance adult protective services. We have produced voluntary consensus guidelines on the practice of adult protective services. And some of the grantees today, I believe, will have worked with those voluntary consensus guidelines. We have a national data collection system called the National Adult Maltreatment Reporting System, which we fondly call NAMERS, which is really the only national set of data on the kinds of abuse, neglect, and exploitation that adult protective services gets involved with. And I want to point out that every state and every territory is providing data into NAMERS voluntarily. There is no mandate or requirement. It is all done voluntarily, and so important to create a database from which to inform the work that we do to make things better. We have a resource center, and we're most recently, through a lot of the COVID and COVID relief funding, we are providing formula grants to state adult protective services programs across the country. And those formula grantees, of course, work in conjunction, as do the grantees under the state grants to enhance adult protective services, with our Elder Justice Innovation Grants that we'll hear about today. We are also responsible for the Long-Term Care Ombudsman Program. And we in the Office of Elder Justice are joined together with the Office of the Long-Term Care Ombudsman to raise up the voices of residents of congregate long-term residential facilities. And we also have an Ombudsman Resource Center. And NORS, which is our data, that's another acronym, National Ombudsman Reporting System. Again, we are very data-driven. We think everybody needs to be very data-driven to be sure that we are headed in the right direction. And finally, elder abuse. There are funds that go to every state unit on aging, not very much, but a little, to be used for the prevention of elder abuse. We have our Elder Justice Innovation Grants, more in a minute. We address late life domestic violence. And I'm just going to skip a few of these. We have a resource center, the National Center on Elder Abuse. And I want to particularly draw everyone's attention to World Elder Abuse Awareness Day, a major awareness effort that is international. It is worldwide. It happens every year in the middle of June. And if you are interested in participating in this major event, please be in touch with the National Center on Elder Abuse. You can find information about them on their website. Next slide. So let's set a context for our investments in the Elder Justice Innovation Grants. Next slide. This is a little bit of a graphic of where we are today, where we hope our leadership is bringing us all together, and where we want to be tomorrow. So the first here is the Elder Justice Coordinating Council. This is a council comprised of the senior-most leadership at 16 federal departments which have a stake in remediating elder abuse. It meets twice a year. The next meeting will be in conjunction with the World Elder Abuse Awareness Day, or WEAD, so stay tuned for that. Talked about Title VII. I talked about the National Center on Elder Abuse. We're going to talk more about those grants. We talked about us. I think we've talked about all of these things. So where do we hope to be tomorrow? We want to have data to drive us forward and make sure that everything we are all doing is premised upon what we know from data. We want to have recommended program standards for all of the programs that address elder abuse and practice models. We are already providing extensive technical assistance to adult protective services programs and seamless partnership with aging and disability services for longer term prevention efforts and also mitigation and recovery efforts. And as I've said several times, we want to make sure that all of these interventions are evidence-based. And I think you'll hear about all of this vision for tomorrow when the main event happens here, which is the presentations by 3 of our 7 current Elder Justice Innovation grantees. So next slide. So this is really just an introduction, again, to the rest of the presentation today. We have 7 current Elder Justice Innovation grantees in this area of longer-term interventions that work. So our goals here are to assess and understand the various community services that produce better outcomes for individuals transitioning from adult protective services, which is a short-term emergent intervention, to broader community-based services and programs that can remediate the harm that's been suffered and prevent recurrence of abuse over the longer term. So we're going to hear from 3 of those 7 grantees today. I also wanted to just let you know, as I close out my part of this session, that we also have 7 additional Elder Justice Innovation grantees who are highest state courts, and they are assessing the fairness, timeliness, safetiness, integrity, and accessibility of the rights of individuals, adults, who are subject to guardianship and conservatorship, to develop innovations to improve the experience of those individuals by reforming, understanding, reforming, diverting away from guardianship, pointing to alternatives that are less restrictive, and in all ways improving upon that experience and preserving the human rights of all adults to make their own decisions. So with that, I think I'm going to turn the webinar back over so we can just get right into the heart of the matter, which is learning from 3 of our 7 Elder Justice Innovation grantees in this area of longer term interventions. So thank you all very much, and I look forward to listening along with everybody else to our 3 grantees.
Thank you, Hillary. It is now my honor to introduce our grantees. First is Dr. Farida Kasim Ijaz, a senior research scientist at the Center for Research and Education at Benjamin Rose Institute on Aging. Dr. Jazz has served as principal or co-principal investigator or consultant on more than 30 externally funded research grants. She has over 30 years of experience in conducting applied aging research, and her specialty areas include examining abuse, neglect, and exploitation among older adults and adults with disabilities, examining quality of life, care, and consumer satisfaction in residential care facilities, and community-based settings, and examining issues related to direct service workers, in addition to examining the oral health conditions of older adults. Joining Dr. Jazz is Tracy Lee. Tracy has worked in the human services field for over 30 years. She started her career in housing, youth treatment, and working with people with disabilities. For the last several years, Tracy has worked for both county and state aging services. And in working for Salt Lake County, Tracy oversaw the active aging program, and she is currently working for the state of Utah and serves as a program administrator for Adult Protective Services. Tracy graduated with a master's in human service administration and is passionate about advocacy and services for vulnerable populations. Following them from Purdue University, we have assistant professors Dr. Marion Liu and Dr. Zachary Haas. Dr. Liu works with Adult Protective Services at the county, state, and national level to conduct applied and translational research around elder justice issues, covering topics on elder abuse, neglect, and exploitation. She is also the co-chair of the National Adult Protective Services Association Research to Practice Interest Group. Joining her is Dr. Zachary Haas. With an educational background in statistics, Dr. Haas works on evaluating the impact of policies, programs, and interventions that affect the ways in which the healthcare system serves vulnerable populations. Finally, joining us from the Weinberg Center for Justice at the Hebrew Home at Riverdale are Joy Solomon and Dr. Kavita Aluwalia. Joy Solomon is the Vice President of Elder Justice and Spiritual Engagement at River Spring Living and the Director and Managing Attorney of the Harry and Jeanette Weinberg Center for Elder Justice at the Hebrew Home at Riverdale. Joy co-founded the Weinberg Center in 2004 and has since provided expert strategic planning, consultation, and ongoing support in the replication of the shelter model in numerous states nationwide, with several more in development. Dr. Kavita Aluwalia, Program Manager and Evaluator, is an expert in program development, implementation, and evaluation. She received both a DDS and MPH from the University of Michigan at Ann Arbor and completed a residency in dental public health at the Veterans Administration in Perryport, Maryland. She has also served as an associate professor of dental medicine at Columbia University College of Dental Medicine, where she directed the college's postdoctoral program in dental public health, predoctoral training and research methods, and led the Global Health Oral Initiatives for Africa and South Asia. An applied aging researcher, Dr. Aluwalia has worked with local and regional agencies to address programmatic and policy concerns among vulnerable adult populations. In addition to partnering with the University of Nairobi to develop and implement program evaluation training for policymakers in Kenya, she has worked with the state of New Jersey to develop recommendations for a 5-year oral health policy plan targeting adults with intellectual and developmental disabilities. I will now turn it over to Farida to tell us more.
Thank you, Sarah. I'm going to share my screen and hope it works this time. Can you guys see my screen? Can you see my screen?
Mm-hmm.
Okay. So we are going to give Tracy and I, my colleague Tracy Lee from Utah APS and I are going to give a very high level overview of our entire grant process. And we will not delve into the services and supports piece as much, but we will give you an overview of what we are doing. Now, I'm going to try this. So our project partners are the Benjamin Rose Institute on Aging, which is an applied aging research center. We work very closely with program managers, administrators, so different community-based organizations. And APS is one of our biggest partners in the work that I do. Utah Adult Protective Services, Utah Association of Area Agencies on Aging, and JUMP Technology Services. Why did we decide to focus on caretaker neglect? So in discussions with Tracy, we got linked to Tracy thanks to a NAPSA webinar where she asked some certain questions about self-neglect, and we started talking to each other. So when this innovation grant proposal was out, we reached out to her and she became very interested, and we started talking about what should we do, what would be innovative and what would be good for your state, for your APS state, so APS in your state. And she wanted to focus on caretaker neglect because it's the second highest type of adult maltreatment reported to APS in Utah. The first highest is financial exploitation, but they have a grant already and they're working on that. So we got excited about the topic because we had done a lot of work on self-neglect, but not on caretaker neglect. And when we started looking at the literature, we found that not only it's the second highest type of maltreatment in Utah, but it's so nationally. And then further research indicated that caretaker neglect is multidimensional. It can come from individual level factors such as a person may have, an alleged victim may have dementia, mental health issues, poverty, or it could be from the caregiver side. The caregiver is frail, is overwhelmed, burdened by trying to care for someone who has dementia or mental health issues or whatever. So there's stress, burden, and issues such as that. Or it could be also environmental or system level, which could be that there's a lack of services where the client and the alleged perpetrator live. And what we also learned was it's not always intentional. People are not mean human beings. Very often it's just unintentional because they can't cope. So what were our goals? We had a two-pronged goal. One was to develop, like Hillary mentioned, a post-APS intervention where we followed clients, alleged victims of caretaker neglect and their perpetrators into the community and offered them case management services for a longer term after APS had closed a case. So this was community transition grant. We transitioning into the community. And then as researchers, and as Hillary mentioned, evaluation, data-driven findings are going to be very important in these elder justice innovation grants. So we had two goals. Did this long-term intervention really prevent a reoccurrence of abuse? And did it improve outcomes for both the alleged victim as well as the perpetrator? So again, our target population are alleged victims of caretaker neglect, but they could have other types of maltreatment going on as well. Perpetrators are informal caretakers. We decided not to focus on providers of services such as a home health aide because they may be in and out of the home. So we wanted people that we could work with on a longer term basis. And now I'll turn it over to Tracy. She's a very exciting person to work with. I'll tell you, we've enjoyed our partnerships. I'll turn it over to Tracy now.
Thank you, Frida. Frida and her team are fabulous, and I appreciate this opportunity to collaborate. So Utah Adult Protective Services, let me tell you a little bit about our criteria for service eligibility. A victim that comes into Adult Protective Services intake, for us to accept a case, they do need to be considered a vulnerable adult. And in the state of Utah, a vulnerable adult is anybody age 65 and older automatically, or someone between the age of 18 and 64 that has a significant physical or mental impairment that impairs their ability to care for themselves. Utah is a mandatory reporting state, and our investigative services focus on investigation and short-term interventions. And our goal is to address protective and identify protective needs. The definition of caretaker neglect is per our Human Services Code 62A-3-301. And the full, it's a pretty long definition, so we only took out a part of it here. But it is the failure of the caretaker to provide necessary care, including nutrition, clothing, shelter, supervision, personal care or dental, medical, or other health care for a vulnerable adult. So what we will be doing is, as Farida mentioned, post APS case closure, we will be bringing on 2 APS care coordinators who will provide long-term case management after APS closure. We will be working closely with our 12 area agency on agings in the state of Utah that cover the 29 counties that Utah is broken out to. And in addition, because we serve both older adults and people with disabilities, we'll be working with other home and community-based agencies to include both aging and disability providers. Some examples of the supportive program and services is if someone is experiencing or identifies through our assessments that they are experiencing food insecurity, we might hook them up with home delivered meals or meals in a senior center, or even possibly a local community shelter that can deliver food or food bank. If they have social isolation, we can encourage them to go to a senior center, help them understand where the senior centers are in the area, what their times are, maybe help arrange transportation to that senior center. Maybe hook them up with a recreation center or a library. And a lot of people suffering social isolation, especially during COVID, maybe we hook them up with some volunteer opportunities where they can really feel that they can give back to the community as well. When they're discovering anxiety, we really want to focus on a trauma-informed approach. Are we recognizing the impact of not only their recent APS case and their recent stress as a victim and or caretaker? Do we need to hook them up with counseling services so that they can work on other issues that may be facing them or issues of past trauma? And then we want to focus on caretaker stress. And I think this is the first study in our conversations with Aisha, with ACL. I think this is the first study where we're also going to take into account the perpetrators. And can we reduce that burnout that often leads to neglect? And can we offer caregiving resources? We have a wealth of caregiving resources in the state of Utah. We have and a great caregiver support program. And can we connect them and help them put some services in the home for the people that they're taking care of to relieve the stress and burden that they may face? Just to give you a little glimpse of Utah, Utah is mostly a rural state. You can see there in the bright yellow, that's considered our Wasatch Front, which is where the majority of our population lives. Everything outside of that bright yellow, the orange and the blue, is all rural areas. And so often services are very small in those areas, not available. Accessibility can be an issue, driving 2 or 3 hours just to get to a major medical clinic. And so we kind of just wanted to give you a glimpse of the state of Utah and how rural it is and some of the challenges we face because of that. I know with some of our APS investigators, they often have to drive 4 hours one way just to get down to the southeast portion of our state to work and to do an investigation. So with this grant, Farida's going to talk about some of the details of the study that we'll be doing, but we're going to be hiring 4 team members for 18-month period on this grant. We'll bring on 2 research assistants, and Benjamin Rose will assist them with data collection, and they'll be conducting assessments, and Farida will explain this more, of baseline and then case at the end of the long-term case management. We'll also be bringing on 2 post-case care coordinators, and we will work with them to develop a training manual on caretaker neglect. It'll include available community resources, and our U4A, Utah's agency for the Area Agency on Aging, are partners in this, and they will be helping us provide this training, helping us provide local resources, and helping our care specialists get connected with resources in the local areas, as they're all different and they vary based on urban and rural. We'll also make sure we are including culturally appropriate services and being sensitive to the needs of families. We'll also make sure we're addressing barriers of service utilization, and that all of the services that we connect people with are individualized and person-centered. When we develop this manual, as with all of our grant outcomes, we will make sure that we are disseminating it and make it available for anybody to use. And Farida, thank you. I am going to turn it back over to you.
Thank you, Tracy. Now, Tracy didn't want to talk about the evaluation. She turned that over to me. But so we are going to use a randomized clinical trial approach, which is the gold standard of conducting research. That's why we have those dice. The dice are in gold, and it's going to be computer generated. So once APS closes a case, computer will generate an ID for a person to go into an intervention group or to go into a control group. And people in the intervention group will be followed over a 4-month period because they're going to receive that intensive case management during the 4-month period. The control group will get usual care, which means APS closes the case. They'll be a research participant, but will not receive that intensive case management. So how are we going to do our data collection? I must talk about that. I'm a research scientist. This is my bread and butter and my passion. So let's start with the control group. The control group will get a baseline right after the case is closed and they're randomized into the control condition. They'll get a research interview and they'll get another interview 4 months later. No case management. The intervention group will get a baseline interview plus service planning. There'll be formal touch bases 30 days after baseline, 75 days after baseline. There'll be a post-test 4 months later and future service planning. In between, there may be many more touch bases between the care manager, the care coordinator, and the client or the alleged perpetrator. There may be many more, but for formal documentation in terms of research, this is the plan. We'll be doing phone interviews because we're wanting to cover the state of Utah. And there'll be research assistants will be collecting the baseline interviews and the post-test, whereas the care coordinators will be collecting the service planning piece and the case management piece. Now, why did we separate the research piece from the care management or the intervention piece? Because we didn't want the APS staff doing the data collection for the case management team to get biased by the research piece. So we've separated the two out. And we expect a response rate of about 30%. So we'll approach, say, 600 people, and we'll get about 200, we think. Not everyone is as excited about research as I am. I've learned that the hard way. And it's, I eat humble pie often when I do research. So that's one of the lessons we've learned. And we'll be doing ongoing fidelity monitoring of how the data are collected. So it's collected systematically between the 2 research assistants and between the 2 APS care coordinators. In the short term, we want to look at the entire picture. So we want to see what happened to the alleged perpetrator and the victim during the APS investigative phase. So we will be getting data from APS administrative data. That's the short-term emergent piece, as Hillary described. Then we have all our steps of data collection, which is the longer-term piece that we will collect through interview data. And these measures that we will include about stress and burden are going to be driven by the stress process model of family caregiving. For the first time, this is another innovation. We are going to try to apply that to caretaker neglect and see if it fits. Some client outcomes, we talked about being socially isolated. Utah is very rural. There may not be services around. So we look at social isolation, feelings of loneliness, and all of this is heightened during the pandemic. Their health and nutrition, the types of services they were refused to. Again, another lesson we've learned in our grants is not that everybody is going to use those services that they're referred to. They may be unavailable, there may be a lack of motivation. The client may tell you, yeah, I'm going to do it, but really do nothing. So we are going to try to find out what they used, why they didn't use it, do they want to use something else instead? We're going to document this rich treasure trove of the entire gamut of services that were offered to try to meet their needs and whether those needs were met or not met, and whether there was reoccurrence of abuse. In order to save time, we are going to do the same sort of thing with alleged perpetrators, although we expect that our sample of alleged perpetrators will be much, much smaller than the third that will agree to participate in our studies. If it's around 200, if we get 25 to 30 perpetrators, we'll be happy. So we know that's going to be small. And one thing different about the perpetrator piece is we're going to track whether they had a reduction in caregiver burden and stress. How would we know that this big collaboration, this network that we've set up with our community partners between APS, with the U4A, the area agencies on aging and other community-based partners, did they think that this was an interesting project to do or not? So we are going to ask them, how they accepted this. After the project is coming to an end, towards the end, we are going to ask them, we want to see if it was feasible to do. Did they accept it? What were some of the barriers they faced? What were some of the successes they saw in working as a team with APS? And we're going to conduct focus groups with senior executives of APS, program administrators, AAA staff, and anybody who participated. And based on the feedback we get, we are going to develop a plan for sustainability. The fund, if we find that we have positive outcomes, Tracy's group is going to go to the legislature to try to get these APS long-term care coordinator positions established. And what we also hope to do is to disseminate this widely at national conferences and, and in peer-reviewed journal articles. Some of our successes, we hope that we develop a long-term relationship with Utah. For example, we started in 2012 with the state of Texas. We are still working with them. And our project is now coming to a series of projects are now coming to an end. We hope to do more though. So this is a long-term relationship. And we hope that, our training, the measures that we have developed, they are all going to be housed in APS administrative database, that they have those to use in the future, the standardized assessment. And most of all, we want to contribute to the field of adult maltreatment, like Hillary said, and we hope that these findings lead to future research and that they become best practices and it improves practice and helps older and vulnerable adults in the future. Thank you.
Thank you, Farida. We will now hear from Dr. Marion Liu and Dr. Zachary Haas from Purdue University.
Fantastic. Hi, everyone. My name is Marian Liu. I am an assistant professor at Purdue University. And as you can see from the title, the goal of our project is to examine, quote unquote, the pathways to safety for at-risk adults served by APS and community-based service providers. So next slide, please. All right, so I just want to make sure that you're aware, this funding comes from ACO. However, whatever we say, it doesn't represent ACO's point of view. Next slide. This is our project team. In addition to Dr. Haas and myself, we also currently have 2 graduate students on the team. Next slide, please. This is the structure of what we're going to be talking about today, some background, approach, and expected outcomes, as well as our expected project impact. Next slide. So first, let's talk a little bit about background. Next slide, please. Well, just in case that you're not familiar with APS, so in the United States, APS exists in every state and territory. So APS is the only government agency dedicated to address older and dependent adult abuse from, as shown on the slide, from the reception to the investigation of abuse, assessment of at-risk adult service needs, and then the provision as well as the coordination of healthcare, social, and legal services. Next slide. Our project partner is Montana Adult Protective Services. In Montana, APS helps older, which is age 70 and older, as well as dependent adults, so people with disabilities. So APS investigators, they carry out the investigation of abuse, neglect, and exploitation at-risk adults residents as well as nursing facilities. They also help develop a protective service plan when referrals to other service providers are needed, available, and accepted by at-risk adults. So in fiscal year 2020, as shown on the slide, there are so many investigations conducted, with all these different allegations, as well as 227 protective service plans created. And in Montana, so investigators, they design a protective service plan for these at-risk adults in need of community-based services. However, once cases are closed after referrals are made, we don't really know what the outcomes look like when community-based services are, whether they're delivered, whether they're taken care of, so on and so forth. Next slide. So then operating under this short-term crisis intervention model, APS investigators, they often close the case once referrals are made to other service providers in the community. So although the assumption is that community-based service providers, they would then assist the at-risk adults, the assurance of service delivery is really lacking. And then aside from the at-risk adults' self-determination, a study has recently shown that there's a very poor communication between APS and other service providers, and not having APS workforce as gatekeepers for these at-risk adults is one of the reasons that at-risk adults come back to APS. It is not uncommon when service referrals are made that at-risk adults are placed on a wait list until service providers are available. So when no follow-up is made, at-risk adults, they lose their gatekeepers, as I already talked about, and they may fall through the cracks while waiting for services, such that they never receive needed services. So next slide, please. What we come up with in this project is what we call the APS case monitor. So this case monitor model is inspired by intensive case management. They often provide to patients or clients of behavioral health, homelessness, or severe health issues such as HIV. So patients and clients, they receive intensive case management. They often require both social and healthcare needs. And this intensive case management team, they facilitate these different services from, medication, treatment, housing, shelter, income, social benefits, as well as legal obligations. So for those of you who work with APS clients, it sounds, our clients also are in need of all these different things. So then the general idea of this project is to employ APS case monitors as the bridge to connect at-risk adults with community-based service providers. So these monitors will check in with at-risk adults until the community-based service providers are able to take the case. The role of the APS monitors is to create seamless response from APS to another agency. So essentially to ensure service delivery after referrals are made, as well as to prevent a service vacuum during this transition. So then this way, what we're thinking is that APS investigators, they would be able to focus on investigations and they develop a protective service plan of whatever is needed of the clients rather than a plan that is more likely to be delivered. So APS monitors then follow through with the protective service plans developed by the APS investigators and ensure each at-risk adult receives the legal, healthcare, and social service remedies unique and necessary to the client. Next slide, please. So since the at-risk adults often need additional social, healthcare, and legal services, reoccurrence of abuse not only burdens APS, but also many of the other systems. Therefore, our proposed project aims to promote the pathways to safety for at-risk adults served by Montana APS and community-based service providers. In order to identify effective community-based services that reduce abuse, understand how APS can better reinforce at-risk adults' transition to community-based services and ultimately decrease recurrence of abuse to reduce the system's burden is kind of the overall goal. Okay, so next slide, please. And just to highlight our partner in Montana, we are going to be working with Montana APS for this 2-year project to ensure that at-risk adults who needed and accepted community-based services referrals will receive services. And Montana APS is very well positioned to implement this case monitor model for their APS clients. And I just want to say that, in 2020, Montana was awarded their 3rd ACL APS state enhancement grant to implement a case monitor model for just the opioid cases. So some part-time case monitors have already been coordinating and prescribing some of the remedies for opioid cases. So this proposed 2-year project, we have been, working with Montana in the past 2 years, working at improving documentation of outcomes as well as this, opioid case monitor model. So what we're hoping to do is to expand this case monitor model to the whole states, to all the clients who are in need of all these services in the communities. So now I'm handing everything over to Dr. Haas to talk about approach and expected outcomes.
Thanks, Mariam. So I will walk through the 3 objectives of project goals that Mariam mentioned and talk about what we plan to do and what we're hoping to generate out of that work. So the first goal or objective, being a little more qualitative, we're looking to understand how community-based service providers work with APS to support at-risk adults living safely and independently in the community. So we're basically trying to get a picture of the collaborative atmosphere or environment between Montana APS and those community-based services, understand how things are currently being done, and see if we can collate maybe some best practices and barriers and things of that nature. So activity-wise, we're going to form an advisory group with the help of APS. We've identified some stakeholders so far representing aging, addiction, and mental health, developmental disabilities, quality assurance, Native American leadership, and folks from the guardianship process. There may be some more that are identified along the way, but hoping to build a good solid team representing all of the community-based services, hold some meetings as well as some individual interviews. And as a result of that work, we're hoping to put together some, I call it collaboration lessons learned. Also going to dip our toes into the podcasting world, so learn some things there, trying to put together some interviews that'll live on, give a picture of, especially thinking of new APS hires, as well as others outside of Montana just interested in how things work and understanding how our community-based services view their roles and what they do, their strategies in serving the population, how they prefer to be collaborated with, as well as barriers and challenges they see in working with this population. Next slide, please. So objective 2 is a little more quantitative. So here we're looking to identify community-based services that mitigate abuse, improve at-risk adults' mental and physical health, and sustain their functional status. So a little bit of background in terms of past work. Marion and colleagues from California, Montana, and Illinois, and probably a few other places, have been working for some number of years to build what we call in its current iteration the ISO matrix. And that's a standardized data collection instrument that has the goal of being embedded into practice so that it operates both as an aid in facilitating investigation, but also a tool that generates some meaningful research data. And for research, I mean both the sort of work that we do at a research institution, the academic view, but also some more pragmatic research within APS just to inform their strategies and plans and things of that nature. So currently in Montana, the ISO matrix is used at case opening, and it, among other things, generates an assessment of abuse level by abuse type. During, while the case is open, that's where the service plan is recorded. And at case closure, there's a follow-up assessment of the abuse level. And so we have some idea of how the abuse level is changing as a result of that interaction or over the time in which the client is interacting with APS. And as Marion mentioned, there's a gap in terms of what happens once the client goes out into the community and it hopefully is interacting with the community-based services. And that's where we're headed next. Next slide, please. Meng put this nice slide together to describe design. So we'll be employing a pre-test, post-test, non-equivalent group quasi-experimental design. And so at case closure, we mentioned that we have the abuse level assessment being recorded in the ISO matrix. We're also going to ask the case monitors to use a couple other forms to gather some information about physical and mental health, as well as instrumental activities of daily living. And besides their activities in the 6 months intervening, after 6 months from case closure, we'll ask the case monitor to collect all of that information again, including the abuse level assessment through the ISO matrix, to get an idea of how these measures are changing while the client is in the community. And we're going to have two groups that we'll compare. So we have the intervention group, those who are receiving the service, and the case monitor is hopefully going to be able to assure that they are receiving and being connected with those services. And we'll have a comparison group, which I say is prescribe the service. The caseworker put these services into the plan, feeling that the client would benefit from those services, but of course the client through self-determination could decline those services, or as Mary mentioned, due to something like a very lengthy wait list, a client may not have that service available. And so that will give us being able to compare those groups. They are a non-equivalent group, not quite as good as Dr. Farida's randomized control trial in terms of that comparison, but it will allow us not to deny services to these individuals and allow for self-determination, just being a slightly different setup. And then the pre-test, post-test, meaning we're going to measure them before and after the time in the community. And the quasi-experimental design just refers to, it's not quite an experiment, but we're going to mimic some of the experimental analysis. Next slide, please. So one of the key takeaways here is that we'll be able to look at the change over that 6-month period in our measures, the physical and mental health coming from the SF-12 measure and Lawton's IADL scale, measuring IADLs, and then the abuse level change from the ISO matrix. And one of the key comparisons will be between those in the, we'll say, experimental and control group, those who receive services and who do not, while controlling for various demographics. Also, we're going to look at the service categories. It was mentioned earlier that the namers collects lots of information. And so we've mapped Montana's, with a lot of help, Montana's services to those 18 namer service categories. And so that's how we'll analyze those. And provided we have enough data, we will dive into each abuse type individually. Next slide, please. So the third objective is a little bit mixed methods. So we're looking to help facilitate community-based services that prevent recurrent abuse. So one of the things we'll do is consult with APS and advisory group members on exactly what we mean by recurrent service use. So one of the questions might be around, if an individual, what's the definition of recurrent abuse or recurrent APS needs? So does an individual come back for an unresolved old need, or do we also include those who simply need APS again because a new issue has arisen? We're hoping to interview about 8 to 10 repeat APS clients. So we'll have to be real careful with that process. We're going to work very closely with APS to identify and reach out to those individuals. We're hoping we can find a group that's willing to interact with us and describe their experience working with APS, working with community service providers, describing what they liked about that process, where they saw maybe some gaps or what they think could be improved. Just get a picture of some of the things that happen. We'll also do some quantitative analysis of the data that we've collected to try to predict recurrence. So just thinking something like logistic regression. And hopefully that will help us, along with the other activities, to identify services that help prevent recurrence, as well as capture maybe some difficulties, particular services that are vulnerable to recurrence. Next slide, please. So potential pitfalls, we'll rely very heavily on APS buy-in. The case workers and case monitors from APS will be doing the data collection and essentially the intervention. We'll be depending upon the generosity of our community-based service provider partners and at-risk adults buying into the work and being willing to share their perspectives and contribute to data collection. And we'll also, one of the risks of a purposeful sample is that the repeat APS clients we interview may not be representative of all the things that can occur. But again, we want to be very sensitive to not putting someone in a bad situation, being careful who we reach out to. But hopefully we get good representation. So I will now turn it over to Dr. Liu to finish the presentation.
Thanks, Zach. So last but not least, just very briefly, let me go through the project impact. Next slide, please. All right, please click again. So, we wanted to test the service effects through the case monitor model. And what we're thinking about, like how this could be pretty impactful, is through the standardized measures that Zach already mentioned, the ISO matrix, as well as the ADLs, as well as measures on physical and mental health. So that could be potentially be implemented across the country. Please click again. And in thinking about Montana, it is a state that covers a lot of rural and frontier areas. So some of the service providers are stretched pretty thin, I would say. So in terms of what kind of services are most effective for what type of abuse, that would be something that we're interested in exploring. And then, hopefully that can develop into a roadmap in terms of what services are most effective for those type of clients in the future. Click again. Last but not least, just like I mentioned, we do think this model could be applied to other programs across the nation. We've been speaking with other states across the country, and Montana is not the only one who are interested in this kind of model. And I'm aware that like in California, case management in the pretty long term is also something that they are very interested in looking into. Next slide. Just like Frida and Tracy, so we're also hoping to disseminate the findings broadly through academic manuscripts, journals. We think that aging service providers would be very interested in this, but also because of just the nature of the clients, service being served by APS, we do think like criminal justice professionals, as well as healthcare professionals and professionals in other areas who have contact with APS clients would be interested in these. We would also like to go to conferences and presenting our findings. And just like what Zach already mentioned, podcast is a new avenue that we're hoping to explore. Last but not least, next slide. We would very much like to thank our partners in Montana, especially the previous as well as the current Bureau Chief of Montana, Michael Hagenlock and Trevor Taken. Thank you.
Thank you so much. Our last team of grantees are Joy Solomon and Dr. Kavita Ahluwalia from the Weinberg Center for Elder Justice at the Hebrew Home at Riverdale.
Great, so thank you so much. And thank you to ACL and to our partners. And we're going to talk today about shelter for older adults who experience abuse, and really looking at shelter impact when clients go from APS back into community. Yeah. So I know this group, we don't really need to talk too much about elder abuse, but of course we do know that a lot, 5 million, almost 10% of older adults in the United States are experiencing some form of abuse each year, and certainly on the rise, and certainly getting to less of them right now during this time of COVID. And in most of the cases, family members and caregivers and people within a relationship of trust are often the most commonly identified perpetrators of elder abuse. And we know that people who experience elder abuse are often at risk in their own homes, and isolated, often unsupported, and very often shelter is not available. And so what we are, really looking to talk about is the understanding that elder abuse shelters are critical, and a intervention where APS clients who come to us as a result of coming into shelter and the services we provide are it's going to be improved on the other side once they're discharged. And the goal of this work is to assess and document the utility and effectiveness of shelter models. And we're going to collect the information and use it to inform recommendations for future research, policy, and practice. We see shelter as a critical component of a coordinated community response, where really in most places there still is a significant gap in service. The shelter models differ from traditional emergency shelter programs, often where there's only housing provided and usually a limited stay. In the shelter model that we're talking about, and you'll hear more about, that in addition to providing safe housing, we are providing holistic, victim-centered services that are coordinated and delivered by a multidisciplinary team of shelter professionals, which often includes lawyers, social workers, public health professionals, and multidisciplinary community-based professionals. In our model of shelter, clients who come in, and in this case, it's APS involved clients, receive medical, functional, social, and cognitive, those needs are addressed. And the potential for recidivism through this model is mitigated by addressing targeted issues associated with the abuse. And that may be legal, it may involve financial abuse and exploitation that needs to be dealt with. It often involves housing concerns. And one of the things that happens is that victims who are in shelter are connected with community-based service on discharge, with the goal here that they will no longer be clients of APS. And the potential that we see for sustainability and effectiveness is improved through the use of community engaged programming that's responsive to community needs and resources. So our work in the shelter model is to fill a gap in service, to provide necessary service for APS involved clients, to figure out what clients want, and often to get them back home. So this slide you'll see helps to, and it's not an exhaustive list, but it certainly can show the referral sources from where many clients come into shelter. And really, though it's not exhaustive, I think really points to a lot of the community services that are working with older adults who are experiencing abuse. And so you can see that it includes legal services, victim service agency, multidisciplinary teams, the court system, law enforcement, and certainly in the purple, adult protective services, where many of our clients are coming from. And we see shelter as part of a critical community resource, and different types of shelter sites, which I'm going to get into a little bit, include, that's okay. Do you want to go back?
I don't think, oh, no, it won't go back, sorry.
Okay. So can we, you can't get it to go back to the, there we go, great, thank you. These are different types of shelter sites, which include skilled nursing, long-term care, assisted living, apartments, motels, and foster home. And we'll talk about that a little bit more, but really want to educate you a little bit about what how shelter fits into community. Okay, next slide. Great. So in terms of what shelters look like, there are generally 3 types of models right now. So model 1, which is what the Weinberg Center is, and I'll talk about that a little bit more, is a shelter program affiliated with a single long-term care facility where we are embedded within skilled nursing, and clients come into the long-term care facility, and there's a multidisciplinary team within. Model 2 is where the shelter program coordinates placement at various housing sites. So for example, for us, one of our partners in this grant in Buffalo, the legal services for the elderly, they are the coordinating site. They're a legal service agency. They receive the referrals, and they have memorandum of understanding with various housing sites, including skilled nursing, where clients that refer to them can be placed. And the final model is other combinations of shelter solutions and support, including our partner in this grant, the Pikes Peak Elder Justice Center, which started 15 years ago as an elder justice coalition and now includes shelter services. So what's really fantastic about these different models is that they look to each community. What are their resources? Who are the people that they're serving? What does the community look like? And what makes the most sense for each community? And so that's how these models really were described and defined. The Weinberg Center for Elder Justice was started back in 2005, really to fill a gap in service as a grassroots effort to deal with those people for whom home wasn't safe anymore. We are integrated into the campus of the Heber Home at Riverdale, which is a 500-bed skilled nursing facility in the Bronx. There was no capital cost involved in creating the shelter. Clients are placed within our campus where their medical needs are met. And the team, which consists of lawyers and social workers and public health professional, go to the clients where they are. It's a flexible and low cost model and highly sustainable. This is the work that we do at the Weinberg Center. And the way that we work is we get referrals from, you can move to the next slide actually. So you see, okay, keep going. Yeah, great. Okay, so our referrals come from these and more this is not an exhaustive list. The team determines who might be appropriate for admission. When clients come in, they're given a care team as well as work done by the Weinberg team, where we're providing legal service and social workers. And then we work in a trauma-informed way to understand what the client wants and then to support that. Often the clients want to return to the community, so we support that. Sometimes they are discharged to the Heber home because skilled nursing is what they need and what they've decided that they wanted. And between discharge and 90 days, we are doing work with the transitional bridge program, where a social worker is meeting with those clients up to 12 weeks to make sure that their return to community is supported and really client-centered. So we're really helping them. And I just love this word bridge, because it's really going from the support that they've received in shelter for their ability to return home back to independence as much as it can be. We can move to the next slide. Back, I think in 2010, maybe a little bit earlier, the Weinberg Center created something called the Spring Alliance. It's a network of shelters and other similar service models with close working relationship, shared resources, technical assistance, and common standards of excellence. And basically, the Spring Alliance involves partners from across the country who are also creating shelter based on really the Weinberg model, but one of those three models that I showed you earlier. And our goal is to support and help each other as we advance the shelter movement. But again, each one of those shelter programs really looks at its own community resources to figure out what model works best for them. This is just to show you a photograph of a client who was APS involved. This is Carmen, and she was referred to us by APS after suffering pretty significant abuse at the hands of someone who initially was her friend and Carmen had let in to help her. And the person who caused extensive harm to her ultimately really deprived her of any modicum of living, including pretty significant financial exploitation. And when APS went in because of a call that they got to a heat emergency, they found her dehydrated and unkempt and malnourished in the apartment, which had been completely obstructed with trash and food and other things. Carmen came to the Weinberg Center, where we were able to help her with the financial arrears, to get her medical care that she had needed, which she had not gotten anymore, to get the ownership of her apartment back to her, to really figure out what she wanted, which was to go home. And we were able to do that for her, get a full apartment cleaning with the support of APS. She went home with our transitional bridge program. And, we're thrilled to, show this example of someone who was able to go home and now live successfully at home with community supports. So we're really, really thrilled about this work. And she's an example of one of our clients. Okay.
Okay, so I'm just going to take over from Joy here and talk you through the ACL funded work. Our long-term goal is really to assess the impact of shelter as an intervention on abuse mitigation and health, functional and social outcomes in older adults who are APS involved. And then we hope to use the learning to inform accessibility and utilization of shelter programs, both by working directly with community, but also in making the elder justice community aware about shelter and how critical it is. For the work that we've been funded to do, this exploratory work, we will be conducting a systematic assessment to assess and document the utility and program evaluation of shelter. So just to walk you through the objectives of the grant, we are going to be using a community participatory model to evaluate whether APS involved older adults who have been in shelter will have measurable reductions in self-reported risk of abuse and abuse indicators, improved sense of safety and support, and improvements in general health, and will also have enhanced connectivity with federal home and community-based services. We also hypothesize that the risk for recurrent abuse will be mitigated after shelter intervention. We have chosen 2 units of analysis, the community as well as the individual older adult. And in terms of community, we will be working with our APS partners in here in New York City and Westchester, as well as 5 additional Spring Alliance partners around the country and their individual APS partners. In working with our community partners, we particularly want to understand how best to work more closely and seamlessly with them, both in order to facilitate referrals to the shelter, but also to help link clients to community-based services and to mitigate potential for future abuse. In so doing, we hope to improve social health and quality of life outcomes for clients. And of course, we will use all our learnings to inform development of dissemination products, targeting future research, policy, and practice. In looking at some of our data from the past, it's clear that a majority of our referrals come from APS. And when they come from other sources, as you can see here, hospitals and social service agencies, the majority of these clients are referred to hospitals and social service agencies by APS. So most of who's coming to the shelter is involved with APS. In our experience, also, we know that APS-involved clients are the most lacking in social support and are very actively at risk. And so these are the folks that we really want to target. This is just a very a graphic model of what we are doing. We've taken a mixed methods approach. As I said before, we have 6 Spring Alliance sites. We will be doing a process evaluation of these sites via site visits, observations, key informant interviews, focus groups, and we'll develop conceptual models for these sites. The process data will be triangulated with outcomes data, in which we will be conducting face-to-face surveys with approximately 200 clients. And there will be 4 waves of data collection at enrollment, discharge, and 30 and 90 days post-discharge. The 2 data sets will be triangulated, and we hope to use our learnings to inform best practices and policy implications. The blue arrow here from our sites directly to our dissemination products just is there to indicate that although we intend to use our data to inform these products, we also intend to work very closely with our community partners to give them an opportunity to directly inform these products. And also it is our hope and expectation that the products will in turn inform site modifications and collaborative efforts with APS partners. As always, I think it's important to talk about some of the considerations in doing this work. We're very excited because this funding allows us for the first time to systematically assess shelter, which is a community-based intervention, and to begin to learn how shelter can mitigate abuse and also improve health and social as well as quality of life outcomes. We are using a community participatory approach because we want to be very careful to represent all the voices, both of the Spring Alliance, but also the types of clients that are served, and also make sure that, you know, we have geographic diversity. So our 6 sites that we will be working with include here ourselves, the Weinberg Center in the Bronx, Buffalo, Syracuse, Colorado,
Cleveland
Cleveland,
and
and
Indianapolis.
Indianapolis. And not only do they represent, you know, different parts of the country, but they also represent urban environments, suburban environments, and rural environments. And they also you know, a diverse group of clients, both racially and ethnically. Having said that, you know, with our desire to sort of be representative, we're aware that the potential effects might be diluted because the sites are so diverse. And this is the primary reason for doing a process evaluation and collecting qualitative data, as well as using a community participatory approach, because we hope to be able to tease out the contextual factors that might lead to differences in effects. And then, of course, we're always thinking about, you know, future directions and our impacts. One of the things that we do want to do is to eventually do some of the work that you, Dr. Farida, and the folks at Purdue are doing in using, you know, RCT or quasi-experimental design. But the work that we're doing now really begins to lay the groundwork for that, and also will inform dissemination products designed to improve shelter, but also designed to help other groups around the country begin to think about developing shelter interventions and implementing them, bearing in mind their policy and local needs and resources. So, you know, we're looking forward to working with all of you and in learning more about what we can do for elder justice together, and to keep our seniors healthy and safe.
Thank you, everyone, for sharing your work with us. We now have time for a few questions. Our first question is for Farida and Tracy. How does one become indicated or relieved from being the caregiver?
Tracy, do you want to take that?
Yes, I read that question. Could you clarify just a little bit? How do they, I'm not quite, I want to make sure I answer it properly.
So it was, how does a person become indicated or relieved from being a caregiver? Like, how are you defining a caregiver?
Okay, so as far as our study, a caregiver would be an alleged perpetrator on a case, someone that's identified as an alleged perpetrator on a case. And I identified that they somehow neglected the victim. I'm struggling answering that question because I'm not sure the purpose and intent of it. I don't think I'm answering it right. So I don't know how they get relieved from being a caregiver. If the case is closed, like if it's closed inconclusive, and we don't support against them, we're going to consider them a caregiver. If we support against them and they're a perpetrator, they will be excluded from our study because they will be considered a supported perpetrator on a case. After APS closes their case, and if it's not, again, they would just be considered a caregiver. And again, we're focusing on family caregivers, not paid caregivers, so that we can reduce that long-term effect of caregiving. If that didn't answer it, go ahead and put a follow-up in the chat. I'm sorry. I read that one in the Q&A and I wasn't sure what they were aiming for.
I also think that it's important that we will be linking caregivers to home and community-based services to address their needs. Now, we did talk about stress and burden, and I see that Dr. Annetsberger asked me a question, why are we focusing only on stress and caregiving when there could be mental health issues and substance abuse issues that caretakers have? And we are going to address that too, Georgia. So It's not going to be just on stress and burden. We are going to look at a gamut of needs that people may have or challenges that they face in their life. And those could be mental health issues, not just for the alleged victim, but also for the perpetrator. So the mental health issues could be connected to substance abuse. It could be a variety of mental health issues. And we found that even in our Texas program, and are finding it in Oklahoma as well.
Thank you. Our next question is for Dr. Liu and Dr. Haas. How are you working with tribal organizations to get to your target population?
I'll get it started, and Dr. Haas, feel free to jump in. So we are going to work with Montana Adult Protective Services, and they already have connections with tribal leaders. So in that way, our stakeholder advisory group meetings will be inviting the tribal leaders into the meetings. And it is quite interesting because I understand that, APS does not have, most APS programs they do not have jurisdictions in tribal lands. Nevertheless, there are a lot of Native Americans living in urban areas in Montana. So that's one of the things that we learned from Montana APS. So in that way, they do qualify to become APS clients. And we are going to work with the tribal leaders in our stakeholder advisory group meetings and trying to understand a little bit more on how we can best help those clients.
That's great. And our next question is for the Weinberg Center. It says, I am a registered nurse and I've been looking for training specific to nurses in assessment of elder abuse. Where does a person find the training? I've searched the state and universities, and there's nothing I can find, and often receive typical responses that either nurses have no role or it's for a social worker, or she's referenced to typical discussions on bruises, and it's like very top surface education needed. The closest program she's come to is SANE training. However, it's not geared towards older adults. She said, we need a Weinberg Center here. Any ideas and resources that you can provide?
Yeah, I mean, I think there are a lot of resources. One of the places I would suggest first is going to the National Center on Elder Abuse, because they have pretty extensive training and resource materials, but I'm happy also, I know we've done some training recently with some physicians to train law enforcement and others. So we have done a lot of training. So if the person wants to reach me offline, I'm happy to also point you to some other resources. But NCEA really is really heavy on training resources around elder abuse. So that would be my recommendation.
Yeah, this is Hillary, and I was going to say exactly the same thing to that question. And Jen, if you need further information, which you won't, I assure you the National Center on Elder Abuse, NCEA, will have the resources that you're looking for. So I also urge you to be in touch with them. But you can also be in touch with me, and I can send you further should you need it. And
sorry, go ahead.
Yeah, I also just wanted to respond real quick to Julia's questions about accepted guidelines for best practices. So the question was about best practices in case management. Frankly, I don't like the term best practices because best assumes that we know there's no further inquiry to be done because we've got the best. So we usually talk about promising practices because there's always room to improve. But in terms of promising practices for adult protective services and their partners, there are guidelines, and I had mentioned them during my presentation. I just want to point you to them on acl.hhs.gov, the voluntary consensus guidelines for adult protective services practice, which were updated just about a year ago. And they are exactly that. They are voluntary, they are consensus driven. It was a community effort to create them and update them. And I suspect you may find what you're looking for or something very close to what you're looking for in those guidelines. So I'd commend those to you.
I just wanted to add something about the assessment. And there, if you go to the National Center on Elder Abuse, they just completed a study of assessment tools for elder maltreatment. And there's a variety of tools that they've listed that are standardized, reliable, valid. And there are others that are emerging and are listed as promising tools. So if you want a link to the tools, I would be happy to send that to you because I served on the technical advisory panel for that group.
Thank you, Frida. Hillary, could you repeat where that can be found again?
Yeah, sure. And this also goes to the other thing that I wanted to point out to everybody. It is acl.hhs.gov. And the easiest way to go from there is just go into the search bar. You can also look in elderjustice.acl.gov, where all of our resource centers and much of our work is highlighted. So that's acl.hhs.gov for more information about the things I've talked about.
Thank you.
And would this be my time to do my little...
Not quite. We have a couple more questions.
Okay, well, I don't want to get in the way of questions.
This one's for Frida and Tracy. How many contact hours will the control group get from their case manager? How many will be in person? And then as a follow-up, how many APS workers are there per county over the state of Utah?
So I'll take part of the question and I'll let Tracy handle the ones on how many APS workers there are. In terms of contact hours for the control group, post APS closure, there are no contact hours. Once a case is closed, it's closed. All the control group would be getting is a baseline interview at case closure, and 4 months later, a post-test follow-up, which will have similar measures and outcomes that it will be exploring to see if there was a change over time. With respect to the intervention group, there are 2 APS specialists who would be hired to serve as care coordinators post APS closure. And since it's a telephone-based intervention, they will be following the client within that 4-month period as many times as needed. But for documentation purposes, they have to complete a 30-day and a 75-day assessment to say what types of service needs were being addressed and if needs were changing and what were some of the barriers to service utilization. So that sort of thing. Did I answer that question?
Yep.
Okay, so 2 research assistants hired for the project and 2 APS care coordinators. Now, Tracy, how many there are, how many specialists and staff you have in Utah? I do not know the answer.
In Utah, APS currently has 26 investigators that cover the entire state. About half of them, well, over half of them obviously are across the Wasatch Front in our rural areas, and then we have them placed throughout our rural areas, and they cover large portions of the state in our rural areas. And then we have 5 intake team members, and we have a centralized intake team that covers and processes all the referrals and then distributes them out.
Thank you. We have time for one last question. This is for the Weinberg Center. Can someone speak to how the shelter program will work in Cleveland?
Yeah, the shelter in Cleveland is called Eliza Bryant. They've been operating for several years, and I know we're at the past the close of our thing. So I would recommend either reaching out to me or to Eliza Bryant directly for more detailed information about the work that they do. But Gina Davis is the person who, they're one of our partners, and I'm sure she'll be happy to answer any questions. But you can reach out to me also if that would be helpful.
Thank you, everyone. I will now hand it back to Hillary to give us a little bit of information on the other grants and some upcoming opportunities, I think.
Yes, and because as Joy has pointed out, we are over time. So instead of telling you about the other 2021 Elder Justice Innovation Grants in this portfolio of longer term interventions, I wanted to hope that you've all really enjoyed hearing from 3 of our 7 grantees about the very exciting work that they're doing. And if you want to learn more about the other 4 who are along the same theme, doing somewhat different things, though, our website, again, acl.hhs.gov would be the place to go to learn more about them. I also wanted to tell you that if this work is exciting to you and you work with adult protective services or, like our grantees here, partner with adult protective services, you may be interested to know that we will be doing another notice of funding opportunity for another round of elder justice innovation grants, including on this theme of what we're calling community connections in 2022. You can look on grants.gov and find the forecast where we sort of say we are forecasting that we will have a notice of funding opportunity, and expect the actual funding opportunity to post there to grants.gov late next month or sometime in March. So I hope we've intrigued you with this, and I hope that you've found the work that these grantees are doing to be inspiring, and that you want to learn more. So I just want to thank everybody very much. Thank our grantees, thank Benjamin Rose, and thank all the listeners for their interest in this really important topic.
Thank you. So thank you all for joining us today, and thank you to our presenters for sharing all of their work. There is a link for a webinar evaluation in the chat that we hope you'll complete. Your feedback is important to us. It helps us improve our programming. The link will also be shared with you in an email soon. We hope you will plan to join us for future webinars that we plan to hold throughout the year. More information can be found about all Benjamin Rose research services, programs, and events at www.benrose.org. Thank you, and we hope you have a great rest of your day.
Thanks, everyone.
Thanks so much. You guys were great. I just want to apologize. As Sarah knows, I sent her an email. I was fighting with Zoom to get on, and so that I'm not usually in favor of dramatic last-minute appearances, and it did sort of throw me off my game a tiny little bit in the very beginning. So I apologize. The rest of you were so incredibly amazing. So I just want to thank you all very much.
Thanks, Hillary.
Thanks for the invitation, and thanks for hosting.
Of course. I'll leave it open for a couple more minutes in case people want to grab some of the links that were put in the chat, but feel free to log off.
Thanks so much.
Thank you.
Thank
Take
you.
care, everyone.